be seeing about the interpretation of fundus images. So what I want to convey over this short talk is I want everyone to recognize what is an emergency, what needs referrals to the ophthalmologist immediately, and what can be sent after some time to an ophthalmologist. So this is a normal fundus image of a right eye. So this circle which is highlighted between the two blood vessels of the arcades is called the macula. This is a normal macula. The center white spot that you see here is called the foveal reflex, and the area surrounding it is called the fovea. So these red lines across the fundus image are the blood vessels, and this small circle here which denotes the optic disc. This here is the optic disc. So I put this slide in the beginning just so that everyone will have an orientation of how a normal fundus will look. Just for a quick look without all the markings, this is a normal right eye fundus. So some of the common diseases I'll just be discussing along with relevant fundus images. So if you see, this is actually the image of a left eye. The inferior area of the retina looks predominantly kind of normal, whereas this area exhibits a pallor. The retina here is not being perfused because of an obstruction in the arteries. So this patient can be diagnosed with a branch retinal artery occlusion. So if the branch retinal artery occlusion involves the fovea, the patient will complain of a drop in vision. So what I want you to notice here is this area of pallor. This area of pallor denotes that there is no blood supply to this area of the retina. So similarly, when artery is blocked, we call it an artery occlusion. When the vein is blocked, we call it retinal vein occlusion. So in an artery occlusion, we will have pallor. In a venous occlusion, we tend to have hemorrhages. So here, we all know the quadrants of the retina. I'll just recap it quickly. So this is the right eye. This part is the superiotemporal quadrant. This part is the superionasal quadrant. Here, one below is inferionasal quadrant, and this part is the inferiotemporal quadrant. So here we can see that the hemorrhages predominantly involve the superiotemporal quadrant, and so we make a diagnosis of a superiotemporal branch retinal vein occlusion. So in association, usually these patients tend to have macular edema, because of which a patient will have a drop in vision. This is a localized branch retinal vein occlusion. Here we can see that only this area in the macula is affected, causing hemorrhages, and this patient will also have macular edema causing a reduction in vision. So STBRVO is a branch retinal vein occlusion and a branch artery occlusion. These patients, it would be better if the patient is referred to an ophthalmologist immediately, so that the ophthalmologist can further work up these patients with OCT and relevant blood investigations to look for any macular edema or any systemic conditions which need to be controlled and give the appropriate treatment for the same. Coming to a central retinal artery occlusion. So here in branch retinal artery occlusion, we saw that only the affected area is pale. The rest of the retina is predominantly normal. In a central retinal artery occlusion, almost the entire retina is pale. I hope you are able to see the pallor and appreciate the pallor, because if you see this fundus image whenever you're seeing a patient or whenever you're screening a patient or somewhere, I would want you to send this patient urgently to an ophthalmologist. It is, I would say it is an emergency, not even urgent. The patient needs an ophthalmologist consultation at once, preferably the same day, preferably within the same hour, whichever is earliest possible would be preferable. This patient will complain of a sudden painless loss of vision. The patient will not have any pain. They'll just tell that they're not seeing anything. So why do we want to send this patient to an ophthalmologist? So that the ophthalmologist can confirm the diagnosis of a central retinal artery occlusion, do an ocular massage, or if needed, a paracentesis to reduce the pressure in the eyeball. So correspondingly, this is a central retinal vein occlusion where the hemorrhages involve all four quadrants of the retina. This patient will also have macular edema and subsequently a loss of vision. This patient also needs a referral to the ophthalmologist for ruling out systemic factors, taking an OCT to rule out macular edema, and if there is macular edema, patient will need to have anti-VEGF injections. So next we'll come to diabetic complications. So diabetic complications are staged. Initially, there is a non-proliferative diabetic retinopathy stage. So, and we have three sub-stages within non-proliferative diabetic retinopathy, like mild, moderate, and severe. And next is the stage of proliferative diabetic retinopathy, where there is early PDR, early proliferative diabetic retinopathy, and high-risk proliferative diabetic retinopathy. So this fundus image is of a right eye showing a few microaneurysms. I hope you're able to see these small red dots in the fundus. These are representative of microaneurysms. So, and one more thing, please do not make a diagnosis of diabetic retinopathy unless the patient is a diabetic. So if there is only microaneurysms, we call it mild NPDR. The next stage comes to moderate NPDR, where the patient can have microaneurysms, hard exudates, dot blot hemorrhages, and in this fundus image, we can see a lot of hard exudates around the fovea. This patient, if there is fovea involving diabetic macular edema, then the patient will have a drop in vision. Coming to the next stage, this is severe non-proliferative diabetic retinopathy, where there can be microaneurysms, hard exudates, dot blot hemorrhages in all the 4 quadrants, venous bleeding in at least 2 quadrants, intraretinal microvascular abnormality in at least 1 quadrant. Similarly, if the fovea is involved by macular edema, the patient will complain of a drop in vision. So now we have seen the 3 stages of non-proliferative diabetic retinopathy. The next stage is proliferative diabetic retinopathy, where there is a development of abnormal new blood vessels, either in proximity to the optic disc or anywhere in the retina. The black circle highlights neovascularization elsewhere. I hope you are all able to appreciate it. And if this patient needs immediate treatment with pan-retinal photocoagulation, failing which fibrovascular proliferations can develop over time, causing a tractional retinal detachment, vitreous hemorrhage, and subsequently other complications. So this is another representative image of high-risk proliferative diabetic retinopathy. The florid neovascularization elsewhere is highlighted. Also, the neovascularization of disc is also highlighted. So here in this image, we are able to see in the periphery some of the laser marks which have been done for this patient. So this patient is a case of proliferative diabetic retinopathy post pan-retinal photocoagulation, and this patient has a pre-retinal hemorrhage in the macula. So like I had said before, if the neovascularization is left untreated, these patients tend to develop associated fibrovascular proliferations. These white membranes that we are seeing over the disc, along the arcades, here, and over here, these are fibrovascular proliferations. And if these fibrovascular proliferations, again, if the patient does not come, subsequently they tend to pull the retina and cause a tractional retinal detachment. So when a patient is diagnosed with high-risk proliferative diabetic retinopathy, the patient, if he or she is seen by an ophthalmologist, the ophthalmologist will advise for pan-retinal photocoagulation. So this is how a well-lasered PDR fundus should look like. There are laser marks covering all the areas of the peripheral fundus. Only the macula is left unlasered. So this patient, the signs of activity of PDR have regressed, and this can be called a stable PDR, stable proliferative diabetic retinopathy post pan-retinal photocoagulation. So this is another representative image of new vessels on the disc. These are quite florid, as you can see. Again, representative image of new vessels elsewhere along the arcades. So this image shows neovascularization of the disc that is present here and a disc hemorrhage. So we'll come to the next set of diagnosis now. So now in this image is of the right eye. What we are seeing here below, the white object which is seeing below is the image of a dislocated cataractous lens. And what we are seeing here superior temporally is a retinal detachment. As you can see, the retina has corrugated, is folded, and there appears to be subretinal fluid below the retina. You can see the difference between this area of the retina, which is reddish and it seems to be attached, whereas this area, which is circled, is detached. So this, what has happened here is a giant retinal tear, and the retina has folded upon itself. The superior part of the image, what you're seeing orange, is just the bare choroid, which you can see by the absence of the blood vessels. The lower part of the retina is still attached, where you can see these blood vessels on the retinal surface. But as you can see, it's quite obvious in the superior part of the image, there are no blood vessels, and this is just the bare choroid. So initially, all these rhegmatogenous retinal detachments will just start off with a hole or a break or for example, a horseshoe tear. So this image shows a horseshoe tear in the superior retina with some surrounding subretinal fluid. So there is a subclinical retinal detachment. This is another representative image of a rhegmatogenous retinal detachment. So what do we do? These patients, it would be preferable to refer these patients to an ophthalmologist urgently. If there is only a break or a limited subretinal fluid around it, these patients can undergo a laser procedure called barrage laser, which will limit the spread of the subretinal fluid and avoid the development of a retinal detachment. However, if these patients present to you with a retinal detachment, these patients will need to undergo vitreoretinal surgery, either a scleral buckle or a pars plana vitrectomy, depending on the condition of the patient. So this image shows total retinal detachment. This here is the disc, as you can see. The entire retina in this image is detached. This is another representative image. The retina of this part is also detached, and here this orangish hue beneath the retina on the left side is a choroidal detachment underneath the rhegmatogenous retinal detachment. Again, another retinal detachment image. There is a giant retinal tear on the right side here, and there are two breaks below. There is this entire retina is detached, and this patient needs vitreoretinal surgery. So what do we do when say you see a patient, there is a retinal hole or a retinal break, and you refer the patient to an ophthalmologist? Then ophthalmologist will advise for barrage retinal laser. So this is how the image of a barrage retinal laser will look like. So what we do is basically we surround the break and the subretinal fluid area with the laser spots. What these laser spots do is they cause an area of abnormally strong chorioretinal adhesion around the area of the break and the SRF. So thus, these laser marks will prevent the spread of SRF beyond the laser marks. So this is a representative image of an exudative retinal detachment. Usually, patients with exudative retinal detachment tend to have underlying conditions in the body. For example, uncontrolled hypertension. There can be many reasons. Basically, initially, what we have to do for exudative retinal detachment is control the cause, find the cause, control it, and the detachment will settle up by itself. So previously, when talking about diabetic retinopathy, I had said that fibrovascular proliferative membranes can be present, and if left untreated, these membranes can contract, causing a tractional retinal detachment. This image shows a thick fibrovascular proliferation on the ST arcade with an underlying macular tractional retinal detachment. So when these patients are taken up for vitreoretinal surgery, say a diabetic patient with either vitreous hemorrhage or a tractional retinal detachment, what does the outcome look like? This is what the outcome looks like. There is laser marks all around, sparing the macula, and the patient's globe has been filled with silicone oil tamponade. Here we can see the silicone oil reflex. So if you see a reflex like this when you're taking a fundus image or when you're examining a patient, and the patient gives history of vitreoretinal surgery, this is just a reflex of the silicone oil. So next we'll see the one innocuous condition. This is asteroid hyalosis, where there is refractile deposits in the vitreous in the patient's eye, and because of which we are not able to see the fundus. But this patient predominantly will be asymptomatic, will tend to have good vision, but will be thinking what is happening. I'm not able to see anything inside, but this patient is reading everything. So nothing to be done for this patient. It's a case of asteroid hyalosis. The patient will not have any problems unless there is coexisting diabetes and they are having a diabetic retinopathy. So this image shows commotio retinae, where the patient has undergone some trauma to the eye. Post-trauma, you can see the degenerative changes to the retina involving the macula and the nasal retina. This image shows a choroidal neovascular membrane with subretinal hemorrhages and hard exudates. This patient needs to be seen by an ophthalmologist for being prescribed anti-VEGF injections. Again, patient may come with a history of trauma. You're seeing the fundus. It shows a hole-like lesion at the macula. That is a macular hole post-trauma. And you're also seeing what you're seeing here, a circumferential sort of lesion, is a choroidal rupture. This choroidal rupture accompanied by a traumatic macular hole. This patient, depending on the configuration of the macular hole on OCT, can either be observed or can be taken up for vitreoretinal surgery. This image shows a normal fundus with a dislocated IOL. The intraocular lens, which was kept in the capsular bag at the time of cataract surgery, has dislocated into the vitreous cavity. This patient will need a pars plana vitrectomy with explantation of the IOL with another IOL being placed, preferably a scleral fixation IOL. So this another image where we are seeing a lot of black pigments sparing the macula, which is present all around. These black pigments are called bony spicules. These are usually seen in a condition called retinitis pigmentosa. These patients tend to complain of defective night vision. There is some mild pallor on the disc, which is also present in retinitis pigmentosa. And you can see, if you look closely, the arteries are kind of attenuated. So seeing this triad of optic disc pallor, arteriolar attenuation, and bony spicules, and if the patient is again complaining of defective vision at night, you can reasonably confidently make a diagnosis of retinitis pigmentosa. One other thing that I wanted to talk is about glaucomatous cupping. So the image on the left shows a glaucomatous cup. What I am encircling now is the margin of the optic disc, and what has been highlighted by the black circle is the glaucomatous cup. The ratio of the cup to the disc is called CDR, the cup disc ratio, and this is what glaucoma consultants will use for making a diagnosis. They can also use it to say look for changes subsequently over a period of time. The image on the right, again, this is the border of the optic disc, and this here is the border of the cup. This is a normal fundus. This image on the right looks normal, whereas the image on the left shows a enlarged cup compared to the disc. So this is high cup disc ratio, probably glaucomatous in origin. So coming to basics of retinal imaging, some traditional fundus cameras demonstrate only the features of the posterior pole. Wide field images demonstrate features of retina anterior to the posterior pole, but posterior to the vortex vein ampulla in all four quadrants. So you want a wider image, what do? You go for ultra wide field imaging. The single image should show retinal features anterior to 4 vortex vein ampullae in all 4 quadrants. So what do you call it when the image of the retina is taken up to the ora in all 360 degrees? It is called pan-retinal imaging. So this here is an ultra wide field image of a rhegmatogenous retinal detachment. You can see that the retina is detached here. There's probably a subretinal band here. Excuse me. So this image on the left is an ultra wide field image. This image on the right is a wide field image. We can see that the more area of the retina is seen on the ultra wide field image. What you're seeing is laser marks being probably done for diabetic retinopathy. So just a slide on AI-based fundus interpretation. Artificial intelligence has been developed that can grade diabetic retinopathy, and it is found to be comparable to those of a retina specialist. It can even detect diabetic macular edema from fundus images, whereas retina specialists will need OCT for the same. Some AI models have also detected a risk of stroke with just a fundus photograph. So that's the end of my presentation. Thank you. I would also like to thank Sister Bharati from Retina Clinic, Aravind Eye Hospital, Madurai, for the excellent fundus images. Thank you.